Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hello, doctor.
Good afternoon.
Good afternoon.
May I know your problem?
Well, doctor, I am a patient with coronary artery disease and peripheral vascular disease with prior stent-supported angioplasty.
I'm having a persistent cough for the past 2 weeks and some shortness of breath. I was also treated for pneumonia.
Do you feel any chest pain, pressure, or heaviness in chest?
No, doctor.
What's your age?
60, doctor.
Do you smoke or drink?
Well, I don't drink, but I'm a regular smoker.
May I know your past medical history?
Well, I have coronary artery disease since 2016. Peripheral vascular disease for over 10 years. Chronic obstructive pulmonary disease and hypertension.
Did you undergo any surgery in the past?
Yes, for a popliteal bypass about 8 years ago. Neck fusion in the remote past and stent-supported angioplasty to an unknown vessel in the heart.
What medications are you taking?
Aspirin, 81 mg daily. Clopidogrel, 75 mg daily. Allopurinol, 100 mg daily. Levothyroxine 100 mcg a day. Lisinopril 10 mg a day. Metoprolol 25 mg a day. Atorvastatin 10 mg daily.
Are you allergic to any medicine?
Yes. I cannot take aspirin because it is intolerant to my stomach. I get stomach upset.
Well, your physical examination result shows your body temperature is 97. Heart rate of 90, blood pressure of 187/105. Cardiovascular studies show normal upstroke, distal pulse, symmetrical heart regular with a normal S1 with normally split S2. There is an S4 at the apex lungs with decreased air, no wheezes. Echocardiogram shows mild bilateral enlargement, normal thickening of the left ventricle with mildly dilated ventricle EF of 40%, mild mitral regurgitation and diastolic dysfunction. Grade 2 nuclear stress study shows fixed inferolateral defects. No reversible ischemia identified. Laboratory data shows normal white cells, hemoglobin 11, BUN of 12.1, creatinine of 0.8, troponin of 0.04, BNP of 5700. You have premature ventricular contraction is random. You have run off 3 beats consecutive, 1 time. Did you have any temporary loss of consciousness related to insufficient blood flow to the brain, a condition we term as syncope?
No, doctor, actually, I'm unaware of it.
Okay. You have cardiomyopathy, ischemic exacerbation of symptoms. Electrophysiologist study is required for ventricular tachycardia. The need for defibrillation will be determined at a later stage. Continue with metoprolol with a little higher dose of 25 mg, twice a day. Continue atorvastatin. Increase lisinopril to 20 mg daily to improve blood pressure management. Take hydralazine 50 mg for blood pressure management.
Thank you, doctor.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Morning, Mr. Peter Jackson. You've been referred to me by your GP, and I'm the first neurologist you've seen, I think.
That's right. I think my GP has some ideas about what my problem might be, but he sent me here, to double check.
Right. Okay, I've got some notes here with his referral letter, but it would be helpful if you could tell me in your own words the symptoms you first noticed.
Well, there were several things which started early last year. They don't sound too bad individually, but together they were affecting me quite a bit. I guess the worst thing was, feeling absolutely shattered, feeling exhausted most of the time. Even when I had not been doing much, I'd never suffered from depression, but I started feeling a bit down. There wasn't a specific trigger.
And any physical pain then?
Well, my right leg, it didn't ache exactly, but there was a real stiffness which made walking slower, and my neck was affected too. Again, not a pain, but more like a tight. Yeah, that's how it felt, and it still does. I started to get constipated too, and had never had a problem with that before.
I see.
And I noticed other things around the same time, like my handwriting. I used to write strong big letters. Everyone always said how distinctive it was, but it was shrinking. Weird how it had changed. I'm right-handed, and I began to notice from time to time there was like tremor, especially that hand. It didn't happen often, but it was worrying. The worst thing, though, was something I noticed when I was in a standing position, washing up or shaving. I'd suddenly feel really unstable on my feet.
That must have been frightening.
Yeah, I was always scared of toppling backwards.
And I gather you've recently started to experience other symptoms.
Yeah, this last month or so. It's funny. I used to love cooking, testing out different ingredients and stuff, but my sense of smell's just gone. I don't like preparing meals nearly as much. Then something which drives me mad is that I keep forgetting things I used to have such a good memory. And the really frustrating thing, especially for someone who was never exactly quite this, that people keep on asking me to speak louder, but I just can't seem to raise the volume now. My mouth feels full of saliva too. It seems to build up more, so I'm wondering if that's got anything to do with it?
Any physical activities you're finding hard?
Oh yeah, driving is hard, so I don't use the car anymore. I can still use keys to lock doors, though sometimes it's tricky, but buttoning up cardigans and shirts is impossible now. It's so fiddly. I'm getting an electric toothbrush too, because the manual one is so difficult. I'm ashamed to admit, my wife insists on cutting up my food too, when she sees me struggling, especially with things like steak.
And you went on to consult other GP?
Yeah, I saw 2 doctors in the same practice for a second opinion. The first mistakenly thought it was a trapped nerve, and the next sent me for physiotherapy, saying it was probably a frozen shoulder. That was wrong, so he then thought it might be carpal tunnel syndrome affecting my wrist.
They were just investigating possible causes.
Yeah, fair enough. And I'm hoping it's nothing serious. I mean, I don't think it's a brain tumor or anything, but I have started to worry that it might be multiple sclerosis. You know, given the symptoms. Then my granddad had dementia. I desperately hope it's not that.
I don't think so, and looking at the tests you've had. A blood test and
A thyroid functional test, but I never heard anything back from that, so I'm assuming it was negative.
Okay, well, I'm going to.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Jenkins really shouldn't be going anywhere at the moment.
Well, it's only to the coffee shop downstairs and his mobile saw.
We can certainly do minor things like showering and getting back and forth to the toilet by himself, but that doesn't necessarily mean he's up to leaving the ward.
He's going a little stir-crazy and he's been in the ward now for weeks. He needs to feel like a normal person again.
Of course he does. But we can't jeopardize his safety. I realize he believes he can, but I really think it's beyond his capability right now.
I'm happy to go with him if it'll ease your mind.
I'd really prefer if he just holds off until he gets the tick of approval. We don't want him undoing all the effort for a cup of coffee.
Now look at question 26. Tegan has suffered suspected second-degree burns from boiling oil to the back of both hands and forearms. He works as an apprentice chef and was lifting a pot of oil when he slipped, inadvertently scalding himself. Apparently, he panicked and his co-workers were forced to hold his arms under cool running water until we arrived at the scene. They also managed to contact his wife, who's on her way. You may appreciate her assistance as he's very distressed and obviously frightened. My colleague has managed to administer oxygen and gave 2.5 milligrams of morphine, but that was as far as he got, as Mr. Tegan continued to put up quite a struggle en route, which is something you'll need to consider before any further treatment. Pain is well controlled at present. Now look at question 27.
So, Mrs. Simpson, do you have any questions before we go into the theater?
I'm sorry, I think I'm just a little nervous. Everything you told me earlier has gone in one ear and out the other.
I see it's perfectly normal to be anxious before major surgery.
Well, if I'm going to be under for such a long time, it just worries me that anything could happen. I know there are dangers involved with it and I think I'm prepared for that, but how will it leave me feeling? I mean, well, I'm really not looking forward to it. It's going to be a lot of rehab and really training myself to walk again. I'm just not sure if I'm up to the challenge. How can I possibly go through all of that when I'm in such agony? It just doesn't seem possible. It's such a long process.
Now look at question 28.
Would you mind if we talk about Mr. Harris in bed 6?
Sure. Is there a problem?
No, nothing like that. The ICU nurse asked me to talk with the patient's family about his situation. I mean, basically explain to them that there's nothing else we can really do for him and that he likely won't survive.
How did it go?
Horribly. They were asking what they should do next. What steps to take. I could barely keep myself together. It was just so hard to talk with them. Just staring at me like that with such blank expressions, it was the hardest thing I've ever encountered. I honestly don't think I'm cut out for situations like.
I assure you it's perfectly normal in such a predicament.
Now look at question 29.
So in bed 5 is Mr. Benjamin Higgins, 75 years of age, under Dr. Monroe. He had elective angioplasty and insertion of stent via the left femoral artery. This morning at 9 o'clock. And him? He has a history of hypertension, hypercholesterolemia, and angina. His medications are metoprolol twice a day, simvastatin, and glycerol trinitrate single spray. He has no known allergies with regards to the operation. There were no complications and he returned to the ward today at 11:30 a.m.
Did he have any pain at all?
He did, just 3 out of 10 mild discomfort. I tried to call Dr. Monroe, but he was in theater. But his secretary said she'll pass it on. He has to remain supine until 5 p.m. today and his wife will have to be informed of his progress. When I received him, he was alert and orientated and his vitals were within normal range. ECG is normal sinus rhythm and that was at 11:45.
Now look at question 30.
So I'll just explain a little on the initial steps of administering the insulin.
Okay.
It's really very simple. So the first thing is the insulin needs to stay in the refrigerator. Now Felix is getting 2 units twice per day. So what I suggest is marking it on a calendar for each day. So divide the day in half with the line. I'd recommend drawing a little box in each section so you can give it a big tick. For both morning and evening doses, the one thing you don't want to do is double dose the insulin. So you turn the bottle upside down and roll it gently. Take it and then take out the syringe.
What happens if you shake it?
I could potentially destroy it, so you want to try to avoid that?
Okay, sure.
That is the end of part B. Now look at part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
White blood cells are predominantly involved in fighting infections and participating in inflammatory reactions, while red blood cells carry oxygen to the body. Platelets help stop bleeding. The normal number of white blood cells ranges from around 4 to 11 billion cells per liter. Newborn babies have a higher range, from around 9 to 30 billion cells per liter, which goes down over the first 2 years of life. And this range is similar to the normal adult range for the rest of childhood. The normal range of white blood cells is not affected by gender, but it is affected by race and nationality. Studies have shown that African Americans have lower baseline white blood cell counts than Caucasians. White blood cell disorders can be categorized in several ways. Firstly, they can be categorized by cause, like those that affect white blood cell production and those that affect the function of the white blood cell. Secondly, disorders might be categorized by which type of white blood cell is affected. In some disorders, all the white blood cells are affected, but others only affect one type. There are 5 major types of white blood cells: neutrophils, which predominantly fight bacterial infections; lymphocytes, which predominantly fight viral infections; monocytes, which predominantly fight fungal infections; eosinophils, which predominantly fight parasitic infections and are involved in allergic reactions; and basophils, which are involved in inflammatory reactions. Thirdly, white blood cell disorders can be classified as benign or malignant. The majority of white blood cell disorders are benign. Too much of one type of white blood cell is suffixed with philia at the end of the word, and too few of one type of white blood cell is suffixed with penia. For instance, leukocytosis is a white blood cell count above the normal range and leukopenia is a white blood cell count below the normal range. These suffixes can also be applied to specific white blood cells such as neutropenia with too few neutrophils or basophilia with too many basophils. Leukocytosis is an increased number of white blood cells. The most common causes are infection and medications like prednisone. Autoimmune neutropenia occurs when the body secretes antibodies that attack and destroy neutrophils. Patients with severe congenital neutropenia are born with this condition due to a genetic mutation and have recurrent bacterial infections. Cyclic neutropenia is caused due to a genetic mutation similar to severe congenital neutropenia. However, the neutropenia does not occur every day but in cycles of about 21 days. Leukemia is a cancerous condition where white blood cells are overproduced in the bone marrow. Chronic granulomatous disease is a disorder where multiple types of white blood cells become unable to function properly. It is an inherited condition and results in multiple infections, particularly pneumonia and abscesses. Leukocyte adhesion deficiency is a disorder where the white blood cells are unable to move to areas of infection.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42. Managing anticoagulation in patients with endocarditis needs a personalized approach using a careful risk-benefit evaluation on a case-by-case basis. There is a lack of high-quality evidence and therefore, recommendations vary according to the clinical condition. Newly diagnosed native valve endocarditis itself is not an indication for anticoagulation. The question of anticoagulation arises in patients who have a pre-existing or coexisting indication for anticoagulation, such as deep vein thrombosis, atrial fibrillation, pulmonary embolism, or an artificial prosthetic heart valve. The question becomes yet more complex in patients with cerebrovascular complications and a coexistent strong indication for anticoagulation. Earlier studies have suggested a significant risk of cerebral hemorrhage with anticoagulation in patients with native valve endocarditis. However, some experts have expressed skepticism about these findings. This skepticism arises from studies that showed a lower incidence of cerebrovascular complications and smaller vegetation size in patients with prosthetic valve endocarditis, where most of the patients received anticoagulation therapy. The mechanism responsible for this effect is thought to be that the vegetation, an amalgam of destroyed cells, fibrin, and platelets, is prevented from growing and propagating by anticoagulation. Some experts believe that the incidence of ischemic stroke with hemorrhagic transformation in patients with endocarditis, receiving anticoagulation, is overestimated. According to this concept, the beneficial effects at least counterbalance the harmful effects of anticoagulation. Moreover, recent studies have shown that patients on anticoagulation tend to have fewer cerebrovascular complications and smaller vegetations. These studies reveal that not only are the cerebral vascular complications less common in patients who were already on anticoagulation when endocarditis was diagnosed, but also there was no increase in the rate of hemorrhage. These were all non-randomized studies and most of the patients had native valve endocarditis diagnosed at an early stage. These studies revealed that there were only beneficial effects of anticoagulation if the patient was receiving warfarin before the diagnosis of endocarditis and initiation of antibiotic therapy. No benefits from anticoagulation were seen once antimicrobial therapy had begun. Therefore, starting anticoagulation and antiplatelet therapy for the sole purpose of stroke prevention is not advised for the patients with newly diagnosed endocarditis. For most of the patients with endocarditis and stroke or suspected stroke, anticoagulation and antiplatelet therapy should be temporarily discontinued. This necessitates a careful evaluation, individualized assessment of the patients, and the risk factors predisposing the patients to cerebrovascular complications such as large or very mobile vegetations, or causative pathogens such as Candida spp. or S. aureus, which may prompt temporary suspension of antiplatelet and anticoagulation therapy in case there is a clear pre-existing or coexisting indication for these agents and surgery is not expected. Consider continuing anticoagulant and antiplatelet therapy, providing that patients are free from the risk factors described above and suspicion of stroke has been excluded. In cases where surgery is considered for the patients with a clear pre-existing or coexisting indication for these agents, then a short-acting anticoagulant, such as intravenous or low molecular weight heparin, can be